of the vaginal and vulval course with a very topic I know, Dr. is management of advanced vaginal cancer. We are privileged tonight to have with us Dr. Nada Salah. She is lecturer oncology in Us University, and she is interning in Asra Aini too. If I am right, Dr. Nada, she is specialized in radiation oncology and radiotherapy. And thanks for accepting our invitation to be with us tonight for this difficult. We are so happy you can start, Nada.
Hello, everyone. Hello, Dr. Basil. Actually, I'm very honored to be with you tonight, and I'm very grateful for Dr. Basil for this opportunity for me to share in this amazing program. I hope you can hear me well. So tonight,
yes, your voice is very clear.
Okay. I'm talking tonight about the management of vulvar and vaginal cancer, which is a topic that it's not discussed a lot in our practice. So my agenda will include a rapid introduction about the vulvar and vaginal cancers. We will go through the vaginal cancer management first. We'll start with the staging, the treatment guidelines, and a rapid overview on different treatment modalities. Then we will move to the vulvar cancer management, also the staging and how to interpret a case of vulvar cancer with treatment options according to the stage, with special highlights on the advanced stage. And we will end with the take-home messages. First, we start with an introduction on the incidence, the types, and clinical presentation of vulvar and vaginal cancer. Both are very rare entity, actually. Vulvar cancer constitutes about 1 to 5% of all the genital cancers. The vaginal cancer is even rarer than the vulvar cancer, only 1 to 2% of the gynecological cancers. The other thing about the vaginal malignancies is that only 10% of all the vaginal malignant neoplasm are purely vaginal. That makes it more and more rare. The types of vulvar cancer is the majority are squamous cell carcinoma. About 90% of the cases are squamous cell carcinoma. And the other 5% are variation between the melanoma, adenocarcinoma, sarcoma, and basal cell carcinoma of less than 1%. Also for the vaginal cancer, the squamous cell carcinoma are 80% of the cases, 15% are adenocarcinoma, and less than 5% are melanoma, lymphoma, and sarcoma. Both have a clinical presentation which is a little bit vague, especially in cases of vulvar cancer, and we will see that later. Vulvar cancer presents as bleeding or discharge, itchy scaly region on the vulva, even ulcer or a warty-like lump. Vaginal cancer presents as abnormal bleeding, vaginal bleeding, either postmenopausal, postcoital, or abnormal vaginal discharge. Sometimes presents with pelvic pain, vaginal ulcer, or even if advanced stage presents with lower urinary tract symptoms or rectal pain. The risk factors for both are similar. Mostly old age is a risk factor by itself. Smoking is a very good risk factor here, and HPV and HIV infection, and also in cases of vulvar cancer and vaginal, the progression of an already present intraepithelial lesion. So let's move for the management. I will start first with the vaginal cancer. It is rarer, and it is more rare than the vulvar cancer, and it will form the smaller part of my lecture today. So the important point about vaginal cancer is that, as we said before, about only 10% of the diagnosed vaginal cancers are purely vaginal. So it's very important before we proceed to management is that we exclude that it is not arise from other gynecological origins, such as the cervix or vulva. Here we have this staging of vaginal cancer, which is this is a combination between a TNM and the FIGO stage. We usually use the FIGO stage as it's more simplified, but they are not so far from each other. They are quite similar. I will not go through the details, but the important points I want you to know is that the stage 1 is the tumor confined to the vagina with less than 2 centimeters. Stage 2 is the tumor invading the paravaginal tissues, but still less than 2 centimeters. The stage 3 We learned at the medical school that stage 3 is always about the lymph nodes, but there are another important point here in stage 3. Diagnostic point is the presence of hydronephrosis. The presence of hydronephrosis upstages the tumor from stage to stage 3. Also, the presence of positive lymph nodes, and one is presents stage 3. In stage 4, stage 4A is divided into stage 4A and stage 4B. Stage 4B is the distant metastasis as all, and stage 4A is the tumor invading the surrounding organs, such as bladder and rectum, extending beyond the pelvis. Now, this is a very busy slide. I know it can horrify you, but it is familiar for the oncologist. If you're not oncologist, you're gonna be shocked. But the thing I want you to know from this slide is not the details, but it is a very simple thing, is that the main line of treatment in vaginal cancers is not surgery. It is the radiation treatment, radiation either with or without chemotherapy. It is in stage 1, in stage 2 until 4A, we apply concurrent chemoradiotherapy as the prime treatment. And surgical resection is not the first go-to maneuver in vaginal cancer. Even in stage 4B, actually, in case of distant metastasis, we can go for concurrent chemoradio. In case of a limited number of metastases, and we can use ablative procedures on the metastasis, meaning that if we have about 2 or 3 hepatic focal lesions, for example, we can use radiofrequency if they were small, or any other ablative regimen, and we can proceed for radical concurrent chemoradiotherapy for the primary tumor. The case in the locoregional recurrence is the same. The only case is that we don't go for external beam radiotherapy and brachytherapy, is that we used it before. It is the regimen that was used before. And it is not an absolute contraindication to use it. So as we said, surgery here in vaginal cancer is of very limited role. It's limited due to the presence of vagina in proximity to the normal tissues such as bladder, rectum, and urethra, which make the surgery very difficult. So the surgery indication here is very, very small stage 1 tumors, less than 2 centimeters, limited to the vagina. And also in the literature, about 25% of the patients with stage 1 and 2 will need to receive adjuvant radiotherapy after the surgery due to the presence of positive margins or lymph nodes. When we talk about surgery, we're talking about local excision, which is rarely used, the partial vaginectomy, radical hysterectomy, and pelvic exentration. So our main topic here in the vaginal cancer is the radiotherapy. It is the treatment of choice in most patients with vaginal cancer, especially in advanced disease. The radiotherapy is privileged by the preservation of vagina and other organs, not like pelvic exentration and surgery. When we use radiotherapy, we use 2 modalities, which is the external beam radiotherapy plus or minus brachytherapy, which has a very good role here. Also, brachytherapy alone is not recommended in most tumors, even in early stage, due to high recurrence rate. That leads us to the question that Dr. Basil asked me the last Wednesday when you asked me about the role of brachytherapy, but it was, I remember it was for the intraepithelial lesions, I guess. I couldn't answer yet because I had my 3-year-old baby screaming in the background. That's why I couldn't unmute myself. I'm sorry. So, okay, I think as an answer for this question is that we can use brachytherapy for those pre-invasive lesions, but I will not go for it as the first option. I will leave it for the recurrent lesions, I guess. But I guess it can be a valid option too. So. For the technique of radiotherapy, we have many types of radiotherapy and evolution all along the last years. On the the previous ages, we had the 2D conformal, then we moved to the 3D conformal and IMRT. This evolution is very good actually for the patients. The difference between each, I know for non-oncologist or non-radiotherapist, it's very difficult to understand the difference, but very simply, the 3D is a geometric shaping. We do the geometric shaping for the tumor, so it can give good dose for the tumor and less scattered radiation to the surrounding normal tissues. While the IMRT is way more advanced technique, which it modulates the intensity of radiation across this geometrically shaped field. So it is way more advanced and way more better than the 3D alone. Moving to the brachytherapy, it is an essential component in treatment of vaginal cancer. During the brachytherapy, we insert a radioactive source directly or near the disease. This way, the residual disease gets extra dose with the normal tissues are spared. There was a published study that found that patients with vaginal cancer treated with brachytherapy had a very better median overall survival, 6 years versus 3.5 years in patients who didn't receive brachytherapy. This is the way the brachytherapy look. We use many different modalities, but for vaginal cancers, we have two famous ones. For superficial lesions, for 5 to 7 millimeters, we use the intracavitary brachytherapy, which is a normal vaginal cylinder, sometimes multi-channel for better coverage and depth dose. And for thicker lesions, we need to insert needles interstitially in the tumor. To increase the dose depth without extra dose to the normal tissues like bladder and rectum. And if you fear of how it looks, how we insert needles intravaginally, we used ultrasound, CT, or MRI during the application to ensure the correct position of the needles. And this is how it looks after the CT. So, when we use the combined external beam radiotherapy plus brachytherapy, the recommended dose is above 70 gray, and even higher doses of about 81 grays are used in advanced techniques like IMRT or MRI planning. And higher doses with better techniques yielded 10% more absolute gain in survival benefit and better local control of about 80 to 90% with reduced toxicity. As for the concurrent chemotherapy that can be used from accompanied by radiotherapy, we don't have enough data for vaginal cancer, unfortunately, due to the low number of cases, but we extrapolated data from the cervical cancer that the accompanied cisplatin chemotherapy, 40 milligram weekly, will yield a very good results if accompanied by radiotherapy, according to data from cervical cancer trials. So, for vaginal cancer, this is a short presentation. The take-home messages: they are rare, but most patients are treated with concurrent chemoradiotherapy. The evolution in radiotherapy techniques lead to outcome improvement in both local control, overall survival with less toxicities. And brachytherapy is proven to be a prognostic factor in treatment of vaginal cancers. We need more data to know the role for systemic treatment accompanied by chemoradiotherapy, accompanied by radiotherapy in cases of vaginal cancers, and also systemic treatment per se, such as immune therapy or other target therapy. We will talk about them later on the vulvar cancer, actually. Actually, HPV vaccine is the most significant difference that can be made for such patients for prevention. And we, of course, need more studies, but it will be harder due to the low number of cases. Okay. So moving to the vulvar cancer. Vulvar cancer management. Vulvar cancer is a little bit, actually way more different than vaginal cancer. I didn't recognize that until I prepared this presentation, actually. For vulvar cancer, it's not like the vaginal cancer where all the stages are good served by concurrent chemoradio. Actually, vulvar cancer needs very, very good staging before we proceed for treatment of each case, because it differs and it affects badly that decision if we misstage the patient. So, for the FIGO staging, also the TNM staging is used for the NCCN guidelines, but FIGO stage is quite close to it, so we will go for it as it is less complicated. So shortly, for vulva stage 1, the stage 1 is strictly confined to the vulva. It is subdivided into stage 1A, which is a tumor less than 2 centimeters and stromal invasion less than 1 millimeter. 1B, tumor more than centimeter, or either of them present will upstage it to 1B, tumor size more than 2 centimeters, or stromal invasion more than 1 millimeter. For stage 2 here is that no nodal involvement, but extension to the adjacent structure, meaning that tumor of any size with extension onto the lower third of the urethra, vagina, anus with negative nodes. So stage 2 here includes invasion of pelvic organs, but in a limited way. For stage 3, here we come back to the medical school, where stage 3 means the lymph nodes. Lymph nodes, stage 3, it is subdivided into 3 sub-stages. The stage 3A, the tumor of any size, but includes extension to the upper 2/3 of the urethra, vagina, bladder mucosa, or rectal mucosa, with or lymph node metastasis less than 5 millimeters. So in stage 2, the tumor extended to the lower third of the organs. In stage 3, it extends to the upper 2/3. Then in stage 3B, the regional nodes more than 5 millimeters, and stage 3C includes the extracapsular spread of lymph nodes. Stage 4, as we all know, stage 4B is a distant metastasis, and stage 4A, where the disease is fixed to the pelvic bone or presence of fixed or ulcerated regional nodes. This is an illustration of that the staging affects the distribution and the survival. This distribution of the cases and the 5-year survival is quite affected by the stage. Logically, when the stage is advanced, the survival decreases and the distribution of the cases are less, fortunately. So there is a point here we need to discuss. Which cases do we consider advanced? So my presentation is about the advanced cases. So do you consider cases with distant metastases are advanced? That will confine us to the stage 4 only. Or do you consider lymph node metastasis as an advanced disease? That's stage 3. Or even extension to the pelvic organs beyond the vulva is considered advanced? Actually, I couldn't get an answer to this question, frankly. That's why we are extending the definition of an advanced stage here. To understand it more, we have a case here. Mrs. S is a 68-year-old nice lady, postmenopausal for 15 years old, diabetic, performance score excellent. She presented to the outpatient clinic complaining of an ill-defined itchy scaly vulvar lesion of 1.5 month duration, increasing in size. She used to use topical soothing cream, but it yielded no response later. The clinical examination of her yielded left-sided single vulvar warty lesion on the left labia majora. So before we proceed to the management of her, or how did we investigate the case well, we need to know that vulvar case is a challenge. It includes many challenges. We have the diagnosis challenges, we have the challenges of management. Diagnosis challenges is that this case is, the vulvar cancer is frequently maldiagnosed. It's maldiagnosed, as we saw, the case presented with itchy lesion. How many of us will suspect an itchy vulva for being a cancer? Actually, it is quite it's difficult to diagnose it as cancer from the first sight. So that's why it's difficult. It's frequently maldiagnosed as vulval inflammation, lichen planus, or any of the other cases that we refer back to the dermatologist. Also for the management, it is a very rare disease with limited number of studies, so we don't have efficient clinical evidence for treatment options. The other challenge is that the difficult treatment decision, we will say why later on. We will first discuss the diagnosis challenge. So for Mrs. S, if we became suspicious, we need to be suspicious here. So for a case of a 68-year-old scaly lesion, not resolving on normal treatment, we need to assess the lesion well. So for clinical examination, the size and number of the lesion, we have to put cancer vulva in our head. We need to be suspicious. So we need to examine well the size and number of the lesions, unilaterality, distance to the midline, assessment of the lymph nodes, and assessment of the other organs. And any suspected lesion must be biopsy. It's better to be non-excisional biopsy, and we'll say why later. Also, radiological assessment. If we suspected also vulvar cancer, we need to do CT or MRI pelvis to assess the pelvic nodes and the pelvic organs, or even PET-CT if it yielded an advanced stage. The lab assessment here, normal routine labs, but the important lab assessment is the pap smear for HPV. That's according to the WHO, there is an inverse correlation of HPV and P53, and the categorization of squamous cell carcinoma of the vulva into HPV-associated and negative subtypes mandatory, using the P16 particularly with immunohistochemistry. The HPV is inversely correlated with the P53, and those of you who are familiar with the P53, if you read any oncology paper, you will know that P53 for us oncologists means aggressiveness. The presence of P53 mutation, it means aggressive tumor. So when HPV negative vulvar cancer is usually associated with P53 mutations, it means that the HPV presence means better prognosis. And meaning that HPV negative might lead us for more intensified treatment in advanced stages. So back to our case. We first examined her as a left vulvar lesion on the labia majora, but when we suspected the cancer, we needed more and more meticulous assessment. So we examined the size, about 3 centimeters in size, not reaching the anus or urethra. The distance from midline was about 1.5 centimeters, with no palpable lymph nodes and no extension to any organs. We asked for the pap smear that showed negative HPV, and we took an incisional deep skin biopsy from the vulval lesion, and it yielded moderately differentiated squamous cell carcinoma of the vulva, stage T1B. When the diagnosis arrived, we asked for pelvic abdominal ultrasound that showed no positive nodes. Also, CT chest was done. In early stages, we don't usually do distant metastatic workup, but it was negative. So we have here a vulvar squamous cell carcinoma SFIGO stage 1B. Moving to the difficult treatment decision challenge. Why it is difficult? It is difficult because we are the main line of treatment here is different from the vagina. It is surgery. Surgery here is important, but the surgery is very aggressive. We will see later how it is. The large surgical extent in a sexually sensitive area, irrespective of the stage of the disease, and that makes the treatment decision very difficult and very annoying for the patient. Now, people who know me, you know all that I'm not biased against gynecological surgeons. In fact, I was raised in the house of a very skillful gynecological surgeon. But look at this. This is a scene that I'm glad that we don't see frequently anymore. This is the classic radical vulvectomy. It used to be called the butterfly resection or longhorn resection. It included radical vulvectomy en bloc resection with bilateral inguinofemoral lymphadenectomy. It used to be the standard of care until late 80s. For treating localized disease. Can you imagine doing such a surgery, such an aggressive surgery for localized disease? And for the more advanced disease, we used to do the same surgery, but adding more chemotherapy options or radiotherapy on palliative basis. So, as for the side effects, I don't need to talk a lot about them. We have infection, lymphedema, psychological trauma, wound complications, urinary complications, sexual impairment. Actually, we're going to use this comment a lot after Dr. Bessel's presentation. So, in order not to reach this stage with our patients, we need to develop an art called the art of treatment de-escalation concerning the surgery of the resection of the primary tumor and also the nodal dissection. As for the primary lesion resection, Thank God, the classic radical vulvectomy was replaced by a triple incision vulvectomy. Byron and colleagues at first introduced it to overcome the extensive resection of the first procedure with similar overall outcome and significantly reduced surgical morbidity. However, this technique still impacted the psychosexual, still had a psychosocial impact remained for the patient. So, partial vulvectomy also marked another further step towards reducing surgical morbidity, preserving the sexual identity of the patients. This is for the surgery, okay? Moving to the nodal, but first we have an overview stated for the stage 1 and early 2 here. For stage 1A, now we know that the wide local excision is applied only in stage 1A, which is very early, and this is the only stage that I can say with ضمير مرتاح إن هي early stage 1A, lesion up to 2 centimeters and stromal invasion less than 1 millimeter is no-nodal mets, and the lesion must be unilateral and unifocal. We do only wide local excision. Wide local excision meaning I don't need to tell you, we are surgeons. 1 centimeter margin resection of the lesion with no needed groin nodal staging. For more advanced stages, they're like stage 1B, which is more than 2 centimeters and more, or 1 millimeter infiltration, or for central lesion, which is more risk of bilateral nodal affection. Also stage 2, small stage 2, less than 4 centimeters, we do modified radical vulvectomy plus groin nodal staging via sentinel lymph node procedure. Sentinel lymph node procedure is the art of de-escalation concerning the lymph node. So classically, the standard of care is that for sentinel lymph node positive, we do complete bilateral inguinofemoral lymphadenectomy, which is the triple incision procedure. If it was negative, we do epsilateral lymphadenectomy. So is this the best we can do? No. We are all familiar with the nodal dissection side effects between lymphedema, recurrent infections, and erysipelas, which is present in about close to 50% of the cases. We have two trials concerning the sentinel lymph nodes. The famous one is the Groins V trial. It is a multicenter trial. It included patients with unifocal tumor size less than 4 centimeters with clinically negative node. They were offered sentinel lymph node dissection. And the primary endpoint here was not the response or the survival, it was the false negativity of the sentinel lymph nodes. Actually, the trial yielded that in patients with tumor size less than 4 centimeters, and clinically negative node, the false negative rate of sentinel lymph node is acceptable, but it cannot be offered for tumors more than 4 centimeters. So, but there is a very important recommendation, because according to this trial, Groins V2, if we did sentinel lymph node and it was negative, that means that the false negative rate is low. We can proceed for follow-up. We don't need to do ipsilateral inguinofemoral lymphadenectomy. But the very important requirement here is doing something called the ultra staging, which is immunostaining with cytokeratin. So if the ultra staging yielded negative sentinel lymph node, we can proceed for for observation instead of ipsilateral inguinofemoral lymphadenectomy. Can you imagine? So another trial here is the Groins V2. The first was Groins V1. The second one here is Groins V2. It discusses the cases, the vulvar squamous cell carcinoma, less than 4 centimeters, the same criteria as Groins V1. But Groins V1 discussed that the sentinel lymph node negative patients can be offered observation because the false negative results are low, actually, if tumor is less than 4. Here in Groins V2, we are discussing the sentinel lymph node positive patients. If the positive lymph nodes were micrometastatic, means less than 2 millimeters, the patients were offered radiotherapy instead of lymphadenectomy. But in cases where macrometastasis was present, the patients underwent inguinofemoral lymphadenectomy plus minus adjuvant radiotherapy. According to the Groins V2, it is accepted to replace inguinofemoral lymphadenectomy with 50 gray of radiotherapy with or without chemotherapy. There was no significant difference in recurrence rate with better side effects. We will avoid the lymphedema, the very bad lymphedema that progresses with lymphadenectomy of pelvic lymph nodes. There is a still ongoing another trial here, which is joint V3. Now V3 discussing the macrometastatic sentinel lymph node positive patients. The sentinel lymph node positive macrometastatic or the extracapsular extension. The trial assessing the possibility to replace inguinofemoral lymphadenectomy that must be done according to the standard of care with higher doses of radiotherapy and adding cisplatin chemotherapy weekly. And the trial is still ongoing. So, according to what we mentioned before, our patient, Miss S, who were diagnosed as stage 1B, she underwent modified radical vulvectomy. She underwent sentinel lymph node, which was positive, so she underwent complete bilateral inguinofemoral lymphadenectomy. Now let's move for the more proved to be advanced stages, which is large FIGO stage 2 and FIGO stage 3. Large FIGO stage 2, which involvement of lower pelvic organs, as we mentioned, but with tumor size larger than 4 centimeters, and the FIGO stage 3, which includes involvement of lymph nodes and upper 2/3 of the pelvic organs. Here is the role of external beam radiotherapy. We can see that external beam radiotherapy with concurrent chemoradio is the main player here. So surgery at this stage is actually radical vulvectomy to pelvic exentration according to the extension, but radiotherapy with or without chemotherapy is the main line of treatment at this stage. So we can do radiotherapy with or without chemotherapy in 3 different ways. We can do it without surgery if surgery cannot be done due to medically unfit patient or it's a difficult surgery for any reason. It's called definitive chemoradiotherapy, or neoadjuvantly, which is done preoperatively, and the role for radiotherapy here is to allow for a better surgery or sphincter preserving surgery. While performing radiotherapy as the primary approach before surgery, it may lead to shrinkage of the tumor and better surgery, but also the healing process of surgery would be compromised because of using of the radiotherapy. So it must be done for very selected cases and and it must be considered thoroughly. Also, the third way is doing it adjuvantly. If we perform surgery first, which is rarely done in these stages, we will actually need the radiotherapy to be used adjuvantly in cases of close or positive surgical margins, in case of 2 or more affected lymph nodes, or 1 lymph node with extra capsular spread or large size. The volumes included in the radiotherapy includes the vulva, the inguinofemoral lymph node, and also the deep pelvic lymph node, the external and the internal iliac lymph nodes. We can use brachytherapy sometimes, but not usually used for vulvar cancer. And the doses, I will not go through the doses. I know you're not interested, but I want to say that if we have a gross tumor, if we are having a gross tumor, means preoperatively or definitively, we are now going to need higher doses, like 70 gray to the primary tumor, or 50 gray, not less than 50 gray for the positive lymph nodes. But if we already perform surgery, we will need post-operative surgical bed radiotherapy with less doses. we have said the difference before. Moving for the systemic therapy, which here we have the cisplatin, which is the preferred regimen used along with the chemoradio, along with the radiotherapy, the cisplatin, just like the cervical cancer. So this is a wrap up for the management of locally advanced cancer. We have pelvic extension radical surgery. We have definitive concurrent chemoradiotherapy. It can be done either definitively or neoadjuvantly followed by surgery. If we done it definitively, we can do assessment 12 weeks imaging after the radiotherapy until the resolve of edema induced by radiotherapy. If we had complete remission in response to radiotherapy, we will follow up, and if there was a residual, we will proceed for surgery, and it will be called the salvage surgery. So our case here, who underwent the treatment for more like early stage, she was on follow-up, but 26 months later, on her regular visit to the clinic, she complained of deep pelvic pain and lower uterine symptoms. The MRI was done and showed pelvic mass fixed to the pelvic side wall and abutting the posterior renal bladder wall. Also, there were unfortunately 3 hepatic focal lesions that were mostly metastatic. That moves us to the actual advanced stage, stage 4, stage 4B, with distant metastatic disease beyond the pelvis. The primary treatment here, external beam radiotherapy, can be used for only palliation. We can use systemic therapy, which is the main line here, or best supportive care if the performance of the patients are poor. For recurrent metastatic disease, we have those kind of chemotherapy to be used, mainly platinum-based, cisplatin, carboplatin, alone or combined with other agents like taxanes. We can add other agents that we will discuss later on, such as immune therapy. We have a trial here. Actually, I was very glad to see it. We have a trial which is Keynote 158 that was published recently. It enrolled 101 recurrent metastatic vulvar cancer patients that were treated with pembrolizumab. Pembrolizumab is an immune therapy. It's the very famous immune therapy. The overall response rate for us as oncologists to use pembrolizumab, we will need to do first a marker called PD-L1. PD-L1 positive patients gain more benefit from pembrolizumab, and negative patients usually have less benefit from it. For overall response rate was surprisingly 10% and median duration of response of 20 months, with median progression-free survival and overall survival 2 and 6 months respectively. This effect was evident in both PD-L1 positive and negative patients. And this is a very good point. Also, another trial called the Checkmate, it assessed the efficacy of nivolumab, but here the cases were virus-associated tumor. In cases of HPV positive, they tried the efficacy of nivolumab. It also yielded a very good control rates, 26% and 26% for vulvar cancer cases, and also for vaginal cancer cases, regardless of the PD-L1 status. The last option we have is a targeted therapy. A targeted therapy, we can use the anti-angiogenic agents such as the bevacizumab. Bevacizumab, you might be familiar with the bevacizumab. It was used regularly in cervical cancer and also in ovarian cancer. We use with bevacizumab, showed efficacy in platinum in addition to the platinum-based chemotherapy, particularly in HPV positive tumors, according to the study called GOG 240. Longer overall survival when added to chemotherapy in HPV positive tumors. Another agent is called erlotinib, which is an EGFR TKI, tyrosine kinase inhibitor. It was positive. It yielded good results in cases of HPV negative. That's why I told you we have to do HPV, and it will be included as a surrogate for response to certain kind of treatments. And this response is, and I believe it is related to the p53 present, the p53 correlation. So I'm done with the squamous cell carcinoma, which is 90% of the cases. Here is a small overview. I will not mention it. I will mention it rapidly. The carcinoma of the Bartholin gland is a rare vulvar cancer with poor prognosis. There are no data of selective lymphadenectomy in Bartholin gland, but this patient will require bilateral lymphadenectomy because of the proximity to the gland, but no actual use. The basal cell carcinoma is rarely associated with lymph node metastasis. It can be managed by wide local excision alone. The malignant melanoma is a big topic and it needs to be discussed alone. It's enough to say that the wide local excision is preferred, and this kind of cases, vulval melanoma, should be discussed in the MDT of the melanoma specialist. So I'm done. We'll go through the rapid take-home messages. This is a previous slide. We faced a lot of challenges during managing our case. The first diagnosis, the diagnosis challenge can be can be passed with the message number 1, in which maldiagnosis can be solved by that any suspicious lesion in the vulva should be examined thoroughly and it should be biopsied. Any suspicious lesion should be biopsied, especially in cases of older postmenopausal women. Also, assessment of lymph nodes and pelvic organs, you cannot forget that. This is message number 1. For the management challenge, it is a rare disease, it's a big challenge. So the only solution here is to encourage participation in clinical trials. Also, for difficult treatment decision, we discussed a lot, but what I can advise you is that MDT is a very good choice. It's always a good choice. Proper identification of the disease stage is very important in cases of vulvar cancer. And we must introduce the art of treatment de-escalation or tailored treatment with each case individually. Message number 4 is the proper decision making concerning the treatment. For stage 1A, wide local excision, no need for nodal resection. For stage 1B and early stage 2, which is less than 4 centimeters, this is a very good diagram where sentinel lymph node biopsy and modified radical vulvectomy are the main lines of treatment. Modified radical vulvectomy is sentinel lymph node biopsy. If it was negative, follow-up is not the standard of care, but it can be done according to the Groins V. The standard of care is doing ipsilateral inguinofemoral lymphadenectomy. And if it was positive, according to the Groins V2, we can use radiotherapy, 50 gray only, with or without chemotherapy, instead of bilateral lymphadenectomy with good results. And in case of macrometastasis, more than 2 millimeters, the standard of care says that we must do inguinofemoral lymphadenectomy until the results of the Groins V3 studies that elevated the dose for radiotherapy and added chemotherapy. We hope it yields a better result to protect the patients from the side effects of lymphadenectomy. For locally advanced disease, we have this diagram we mentioned before. And for stage 4 disease, we have the chemoradio, which is mostly in palliative intent, and the systemic treatment, which is chemotherapy, immunotherapy, and target therapy we discussed. Message number 5, the most important message, is that the HPV vaccine protects our grandmother and mothers and all our precious ladies from a very bad disease. And I will have this chance to invite you all to our annual meeting in Luxor, Jollyville in February 2025. You are all welcomed. Thank you so much.
Thank you so much, Dr. Nada. And you always remind us that we'll not be able to be a doctor because I will be having exam, studying your lecture and having CSGO exam in Rome to here, not to the acute which one of the best really in Egypt.
Thank you.
So do we have any questions from the floor audience or the virtual attendees online? Any questions? Or it was very clear? So now that it looks like it was very clear
Thank
or
God.
very sophisticated.
I think that, yes. I tried, wallah.
Yeah. So we have a question from
Hi, Dr. Nada. Thanks for a very helpful presentation. I just don't understand the value of bilateral inguinal lymphadenectomy. If the tumor is bilateral, not cross-angle midline, why do we address the other side here?
Have you got the question, Nada?
Yes, she's asking about the bilateral lymphadenectomy in cases of sentinel lymph node biopsy. Positive?
Why if it is not crossing the midline and we have unilateral positive sentinel lymph node, we are going to do bilateral inguinal lymphadenectomy?
Yes, in case of, according to the guidelines, the standard of care is that if the sentinel lymph node biopsy was positive, that means higher possibility of contralateral affection. So if it was positive, we must do contralateral bilateral lymphadenectomy. And there are ongoing studies to de-escalate this. I know it is very aggressive.
Let me answer, Abir, that as you have seen that okay, and still the practice
I cannot hear you very well, Dr. Basil.
the practice have been de-escalating. Sorry. ممكن تندعوا بس هنغير بس المايك بتاع
تمام.
of cancer have been rapidly escalating as inguinal lymphdectomy to more and more conservative in the primary lesion to just wide local excision with margins and to central lymph node instead of lymphadenectomy. So I believe that in the very near future, we are not going to do bilateral inguinal lymphadenectomy. This is because the rarity of cases, the rarity of randomized trials, but for sure, I'm dead sure that in very few years, we will not have to do contralateral inguinal lymphadenectomy because all lymphadenectomy cancer is escalating, okay? So we have a question, Dr. Amir. How are you?
Hi.
Hello.
Yeah,
We
hi.
are missing you, دكتور أميرة. هتيجي امتى مصر بقى؟ مش عارفين نشتغل من غيرك. او بمعنى اصح عاملين نعمل انجازات وحاجات حلوه من غيرك.
That's sweet. Honestly, the presentation was incredible. Yani, even when I tried to lose concentration شوية, I always came back. It was a really good presentation. It was very informative and very summarized. Had lots of screenshots. دكتورة ندى بعد إذنك يعني to study them later. And it makes so much sense. But the part you were explaining بتاعت الدكتور باسل موضوع bilateral inguinal lymphadenectomy لو هو unilateral كان بيقطع الصوت ما كانش فيه شبكة عندك. Can you just say it again, please?
Yes, just de-escalating. هو في some sort of يعني collaterals between both of inguinal nodes. I totally believe this is not evidence-based, of course. We have to de-escalate. In the very near future, we are not going to do bilateral
Yeah.
passing the middle. In the last case, if you remember, do that. We did only in the case 2 weeks ago. You were not here.
I wasn't with you, no.
Yes, Hamro was with me in Zahra.
Yeah. Good. يعطيكم العافية. دكتور ندى يعطيك العافية. It was brilliant
Thank you. Thank you so
presentation.
much.
Really, really fascinating. Very easy, yet very informative. And when you see them, you think it's an easy presentation, but everything was there صراحة with all the guidelines and all the references. Excellent presentation. Thank you very much. We really appreciate
بختار
it.
المحاضرين مش بختار المحاضرين من فراغ. I have my own vision.
You're basically you're a boss.
Yes. So thank you. That be recorded and will be published or broadcast on our. Okay, and that's now we finish our vaginal and vulvar cancer module, and next week we are going to start lectures of gestational trophoblastic neoplasia module. Next week we are going to have the management overview of gestational trophoblastic disease with Dr. Muhammad Anwar from MTI and Shams University, and then the week after we have pathology of gestational trophoblastic diseases with Dr. Dina Saman from Shams University pathologist. So thank you so much and have a good night and happy dreams. Bye bye.
Good night.
Bye, good night.